everyone. Welcome to Side Project HQ. My name's Layla Secca, and this is our podcast where we explore all things about middle life and all the questions that we're talking about in the bathroom, but not actually talking about out in public. So I'm here with my friend Julie.
Hi, I'm Julie Legal, and Layla, I feel like you and I do talk about this stuff in public, but that might be more of an us problem. I'm really excited about what we're going to talk about today, because what we're going to talk about today is something I heard of for the first time, kind of like a whisper when I was 43 years old, where someone was like, well, maybe a certain thing that was happening to me is perimenopause. And I was like, what is perimenopause? I'm way too young to be going through menopause. What are you talking about? And I discovered there's this whole world out there called perimenopause that apparently explains all the reasons that things are changing and we're going crazy and it lasts 100 years and no one talks about it or teaches you about it. And now it's like all my friends and I can talk about, and I'm excited to talk to you about it and actually get maybe slightly more educated than I have on TikTok and Instagram so far.
Totally. So before we start, safe harbor statement, Julie and I are tech executives after all, so we're always going to go back to our roots. We're not doctors. Allison's not a doctor. We're not trying to give you medical advice. If you hear something here that piques your interest or that you want to learn more about, go talk to your doctor about it, right? Like, we're just trying to have an open dialogue about what the hell is going on with our bodies and our brains and our emotional states and the, midlife.
Our facial hair.
Our weight gain, there's just no end of things we can talk about, but we're very excited to start it off, and we are very excited to start off with Allison. So, Julie, do you want to give a wee intro on Allison, and then we can let her talk a bit and get going?
Absolutely. We're sitting here today with Allison Lewin. We're so excited she's joining us. Allison is the founder of Menowar, which is, by the way, the coolest name I've ever heard. It's a one-stop shop for women who need help navigating menopause and perimenopause. She's a certified menopause coach, and she provides education and tools to help women navigate menopause. Additionally, she's a rep for Menopause Cafe, a global nonprofit that hosts open conversations about menopause. And we're so lucky to have her here to answer some of our deepest, darkest questions. Welcome, Allison.
Thank you so much, Julie and Layla. It's great to be here and be on your first podcast. So super exciting.
So let's start with this. Okay, what is perimenopause, Allison?
Yeah, let me do a little definition. So perimenopause is a transitional period leading up to menopause, during which a woman's body is going through hormonal changes that can affect her menstrual cycle, her mood, and her overall health. So perimenopause, a lot of women think, as you said, Julie, it doesn't start till I'm in my 50s. It often starts in one's early 40s, and it can last from 4 to 10 years typically. And symptoms will creep in. Obviously, the telltale one for a lot of women is their periods start to fluctuate and change. Their flow might be heavier or lighter. They may skip months, what have you. But those symptoms will carry on again from 4 to 10 years. And then menopause is officially, by definition, when you've gone 12 months without a period. So a lot of women say, well, what if I don't have a period? Or what if I have irregular periods? What if I'm not using an IUD and I don't get monthly cycles? Well, then doctors, the best doctors, typically go on your symptoms. And we'll talk about the array of symptoms that people experience. But if you're having a collection of these typical menopause symptoms, a doctor will say, you're almost definitely in perimenopause. And again, typical age is early 40s. Menopause, actually, the average age is 51. Again, it ranges, and we can talk about the different ways in which women enter menopause, but that's the definition of menopause. And then postmenopause is basically after you've hit that menopause time period, that one day where you've gone 12 months without a period, you're postmenopausal, and you're postmenopausal for the rest of your life. So those are the basic definitions.
That's interesting. So menopause itself isn't actually a phase. It's really just a mark of transition from perimenopause that lasts a long time and postmenopause, which God willing also.
Exactly. Though I will say I and others will use menopause as kind of a collective term to talk about all these phases. Like, you're going through menopause, you're in the menopause transition. That's typically, how people talk about it.
Okay. So dumb question. How come no one ever told us about this? Like, we got puberty education. We went through pregnancies, some of us on this podcast, but no one told us about perimenopause. I'd never heard the word before? Like, why was no one talking about this?
Yeah. No, all this terminology is just coming out of the closet. So it has been taboo for many years, and there's been a stigma around talking about menopause. It's a lot of different factors. I'd say there's a stigma around aging. In this country, women typically, more so than men probably, are made to feel older, less attractive as they're aging. And menopause is something that kind of signals that you're in those post-reproductive years. So women in society in general, I think about, oh, you're getting older, you're at the end of your fertility. And I think women also feel a sense of identity with being able to reproduce. And when they can no longer do that, oh, wow, this is a dangerous time and I don't want to talk about it. So I think people avoid it. I think there's also a lot of taboo in this country about reproductive health. Again, how many people have conversations about periods or about, endometriosis and conditions that affect women's reproductive system. I think infertility and fertility and pregnancy have become safe ground, but the beginning and the end and the cycles in between, not so much a conversation topic, like you said, unless you're talking in bathrooms. So I think there's been a lot of stigma around it. And so therefore, I think because of the stigma, women haven't been educated. They haven't had the open conversations with other women. Another factor is that a lot of doctors are not aware of all the factors of menopause. Even OBGYNs, there's different studies that indicate between 20 and 30% of OBGYNs do not have any education in menopause. And even if they had it in medical school or the residency, it was like an hour, like one elective. Crazy, right? Like you go to your OBGYN for expert advice on your reproductive health, and a lot of doctors just don't know or are misguided. So that's a big factor as well. And then I think it's just, society and gender norms, how we talk about things. And I think women's health concerns have often been marginalized or overlooked in a lot of different categories. And this is just one big example.
So, Allison, you said something I want to touch on really quickly. You sort of said people aren't educated. And so, the people are making decisions without any information. It's a little odd to me that, half the population moves into this stage for over half of their life, hopefully. And no one seems to be studying, or very few people are studying it. It's, to your point, it's getting a little bit more there. But when I was a kid, right, and this is a podcast for our generation and anyone else, but we're definitely going to be making reference to where we are in our generation. I remember people were like, don't take the hormones or you're going to get breast cancer. It was just if you take the hormones, you will definitely get breast cancer. So a lot of my mother's friends, my mother's age people, didn't take it. And not all of them, but a lot of them have terrible osteoporosis or these other sort of things happening. So we'll break down what happened with hormones and menopause for those of us from this generation and kind of how things have shifted and what the landscape looks like now for us a bit.
Absolutely, Layla. This is one of the biggest, again, sources of misinformation, disinformation that I like to address with women, because a lot of women are just scared. They're scared of taking hormones, and therefore they don't seek a potential really great solution to mitigate their symptoms and help them live a longer, healthier life. The WHI study was started in 1993. It was the largest women's health study. It was 160,000 women. And the main purpose was to see the common causes of death and how hormone replacement therapy, or we call it now menopause hormone therapy or menopause therapy. So you may hear me say MT or MHT, that's hormone therapy. So it was supposed to run for 15 years. And then 2002, it was abruptly halted, and all this press went out. There were all these news conferences about the fact that estrogen and progestin, the combination therapies for menopause hormone therapy, increased the risk of breast cancer, heart attack, stroke. Breast cancer was the focus, but basically they said the benefits outweighed, or the risks outweighed the benefits rather. Again, this is disseminated to the media, and apparently a lot of the people who were controlling and executing this study weren't even consulted before this announcement was made. And so let me kind of break down some of the reasons why this study was problematic, because a lot of people think it's not a good study to rely upon for the safety of MHT. It was poorly designed, it was poorly executed and reported. And so first I'd say the HRT that was used, or MHT that was used then, is a different form than what's used today. So they looked at one dose of estrogen, or like one kind of estrogen, and one kind of combined therapy, estrogen and progesterone. And it's actually the progesterone that had the impact on breast cancer, not the estrogen. The estrogen only arm actually reduced the chance of breast cancer. So that's kind of an interesting fact a lot of people don't know. The doses used were higher than what is typically used today. And again, another thing I kind of tell people, have you ever taken birth control? Wow. Well, guess what? The hormone levels in birth control are way higher than what's in MHT. So if you felt safe taking birth control, then you shouldn't have a problem kind of conceptually being okay with MHT. Another big factor was older women were the focus in the study. The average age was almost 63. So when you think about that, we talked about how people typically enter perimenopause in their early 40s, and the average age of menopause is 51. So these women typically were not given this therapy during the time in which it would be most effective. And what we say is that, again, MHT can be a great source of feeling better and living longer throughout your life after perimenopause, but it is most effective, if given within 10 years of your last period or by the age of 60. Now, those constraints are being loosened and talked about and researched, but that's a general guidance. So long story short, the earlier you take it when you start to have symptoms, the better off you are in terms of mitigation and long-term health. And so when you think about the average age being 63, well, women were more than 10 years away from the start of menopause. So they didn't have that early intervention. And they hadn't taken HRT before. So they went years without, the suboptimal hormone levels. A lot of the participants of the study also had prior health issues, obesity, alcoholism. There may have been occult tumors that, weren't detected. And so when they say that it caused breast cancer, that tumor may have been present before the study and they didn't know it. So that's another thing. So there's a lot of different issues with the study. And again, as I said, the problem wasn't with the estrogen. It was with the progestin. And the progesterone used now is different than what was used in the past. And I just want to talk about the benefits of hormone therapy. Again, we'll talk about all the different symptoms because they're over 40, depending upon who you ask and how you categorize them. But I'm just going to read a statistic that there's a pooled statistical analysis of 30 clinical trials that found that women who began hormone therapy before age 60 had a 39% lower risk of death than women who didn't take hormones. Just like think about that and process that. And the specific things that it helps with is cardiovascular disease. It reduces the risk of diabetes, osteoporosis, and there's more and more indicators that it may help with brain health and may reduce the chance of dementia. And I can say, my mother, passed and she had Alzheimer's. The thing that women fear probably more than breast cancer is dementia or Alzheimer's. And it actually may have protective impacts. So all I'd like to say, and kind of summarizing, is that study wasn't designed right. The participants weren't representative of the people that would most benefit. And there are really great benefits. Now, that said, there are people who it is contraindicated for them to take MHT. If you have blood clots or history of cardiac issues, liver disease, if you personally have had breast cancer or ovarian cancer, then often the doctor, it's a case by case basis, but they'll often say you shouldn't take MHT. But the majority of women are able to take it very safely.
That is so reassuring here. I will full disclosure, I am on hormones, and it was interesting because I actually saw a doctor yesterday and it's time to schedule my mammogram. And they were like, well, you really need one now that you're on hormones. And I was like, again, this is not the doctor prescribed my hormones. This is more of a generalist, but I'm like, this misinformation is still out
everywhere.
There. It's like a rumor that can't, die.
In the stats I told you about OBGYNs not being knowledgeable, think about how much worse the stats are for primary care physicians or other specialists. They just have no idea. And so I don't blame the doctors. I blame the education.
Exactly. Allison, you mentioned symptoms, and I do feel like we went straight to the HRT and the MHT. But I'm glad you addressed symptoms because, I got told about perimenopause, but I'm on an IUD. I have no idea what's going on. I don't have a cycle. And I've now come to be under the impression that everything that goes wrong from the age of 40 and beyond, if you are female, is probably a perimenopause symptom. But I'm guessing that's not completely the case. So what are the symptoms? Are there certain categories that they fall into? Yeah. Can we blame everything on perimenopause once we turn 41?
It's so funny you say that because I literally say to a lot of women, like anything that's going wrong, it may be perimenopause.
It's like the Mercury in retrograde of middle-aged women.
Okay, you tell me to blame everything on, which actually I think is reassuring. Like it's not you, it's not your problem. It's the hormones in your body that are raging. So symptoms, I kind of categorize them as there's physical, there's cognitive, and there's psychological. Physical, I think everybody's familiar with hot flashes. They call it hot flushes in the UK or night sweats. They're all the same. And the reason why they call them hot flushes is like, it's not a flash. Hot flashes can last several minutes and be super intense and like make you go red in the face, like make you sweat, just make you so uncomfortable and be super distracting. So I don't treat them lightly. And I think also the research that I've read is that the hot flashes specifically are the most important thing to try to mitigate because those can have some long-term implications. Again, there's even some research. Dr. Lisa Mosconi wrote a book called Menopause Brain. And in it, there's some theories about the plaques in the brain that can lead to dementia or Alzheimer's can be caused more so by hot flashes. So that's one, big category is physical. There are so many different physical symptoms. You'll see me drinking my water often. Dry mouth could be a symptom. Dry hair, dry skin, acne, heart palpitations, tingling sensation. Some of these are more common, but others are less, are more unusual. But there are some really unusual ones. Having a funny taste in your mouth or having a different body odor are some physical manifestations some women feel. But let's talk next about the cognitive. I think we've all heard about brain fog, that like, short-term memory is just gone. I go into the room and I forget what I was going to find. Or even, I try to remember 3 things. I can remember 1. So this fuzzy feeling of just not being able to remember things or not being able to process information as quickly. And maybe you feel like you're in a fog, literally, like you're just not as honed and as sharp as you used to be. So that's, I think, a very important one that women get really concerned about. It's distressing in your life if you feel like you can't function. And I think it's one of the primary reasons why about 10% of women leave the workforce during menopause because they feel I just can't perform. Yeah, 10%. And even more like turn down promotions or leave a job or transition to something a little bit, less intense. So that's a big one. And then there's the psychological aspects, which are also incredibly distressing. So anxiety and depression are way more common in women during perimenopause and menopause than other times. Now, if you had a history of any kind of these mental health issues before, you're more likely to probably face them and maybe face them more intensely in menopause. But they can really spike. It's very common for women to have panic attacks in menopause and just not know what's going on and why they're happening. One other one I want to speak about on the physical side there's a big group and categorization of symptoms called the genitourinary syndrome of menopause, GSM. And those are all the stuff that goes on down there. So it's vaginal dryness, irritation, pain during sex. It can be frequent UTIs, urinary frequency, stress incontinence. Basically the decreasing estrogen in our bodies is making all these tissues weaker and the pelvic floor muscles aren't as strong. And so you're more prone to a lot of different issues. So women get really embarrassed to talk about it. They don't want to go to the doctor and mention their sex lives. But the more you kind of reveal and are very upfront and direct about what's affecting you, the more they can address it because there's different ways in which they try to remedy those problems based upon the symptoms you have.
Yeah, I think that we made kind of a joke in the beginning about like, why do I pee in our first sort of intro? Why do I pee every time I exercise really hard? So, that definitely, that stuff's going on. And I have plenty of friends that have had surgeries and done different stuff to try to address it. But, no one talks about it, right?
No one talks about it. The one thing I'll say, I'm a poster child for vaginal estrogen. Vaginal estrogen is like the best invention and like all women should use it. I say that, categorically, but, a lot of women are also confused. Like if I'm taking a patch and I have a pill, like, can I use vaginal estrogen as well? Absolutely. You can use many different forms of estrogen. And just to talk about forms for a little bit, the typical regimen that most women are on if they're perimenopausal or menopausal and they're having symptoms and they want to address it. They are typically going to take a form of estrogen and a form of progesterone if they have a uterus. If they don't have a uterus, then you don't need the progesterone. The progesterone is to protect the endometrial lining so you don't have a higher risk of endometrial cancer, basically. But there's so many forms of estrogen. There's pills, patches, rings, sprays, gels, and there's vaginal estrogen, which a lot of women, again, you might have a patch, you might use the vaginal estrogen as well. Actually, I will tell you, I'm on 3 forms of estrogen. I take a patch, I take vaginal estrogen, and I take a vaginal suppository to get in that, the vaginal canal.
Wait, what's the difference between the last two, the suppository?
Yeah, so vaginal estrogen can be great. Like you can use, basically insert it like a tampon into your vaginal cavity but you can also spread it on the exterior that might get irritated. Your vulva might be irritated due to that tissue being thinner and drier. So you can insert it or you can rub it around the outside. Now, if you really want to get deep in there and you want it to stay, like I find, quite honestly, that the suppositories work better. They're usually like a capsule or like a little kind of pill format, and they'll dissolve over time versus, not to get graphic, but if you're squirting a lot of cream into yourself, that might come out. And so you want to do it before bedtime if you're going to use that methodology. Yeah. That's candidly why a lot of women prefer the suppository.
Why do you like it so much? Sorry, we're just going to do this. Why do you like it so much on the vagina? Like, I mean,
on the outside.
Okay.
Yeah.
But like,
it's also quite honestly, you not only want to put it on your vulva and vaginal entry, but you want to put it on the urethra too, like where pee comes out, because, we talked about all these urinary symptoms. Vaginal estrogen can help relieve some of these urinary symptoms. And so literally you can use it for the rest of your life. And I will tell you again, myself and a lot of other women have really bad irritation and dryness as perimenopause was, ending and menopause was starting. And this like cleans it up and makes it feel so much better and can help women avoid that painful sex. So
great.
I'm starting to see, my algorithm is starting to give me things about about estrogen on the face. Is this the next frontier? Because that is not something I have a passion for progesterone, but are we going to start putting it on like Nivea body lotion now? Like
slathering it everywhere. You don't want to put too much all over your body because your body is absorbing it. And so you don't want to have too high levels if you're putting it everywhere. But there is a lot more talk of potential benefits of putting estrogen on your face to help decrease fine lines, reduce the signs of aging. I will say I have not come across studies that specifically research how safe that is. And what I have read is that you probably want lower levels, lower percentage of estradiol in the creams you use on your face. And there are a lot of compounded products, a lot of the menopause telehealth organizations or compounding pharmacies will make products specifically for the face. So I've heard some dermatologists on podcasts talk about it and say, this is the next thing. Like you should be using sunscreen. You should be using tretinoin, which is retin-A, and you should be using, estrogen in your face. So TBD, research studies still yet to be determined. But it could possibly have some good implications. Because you think if it's improving the skin and surface of my vaginal area, well, then it probably helps in other places too.
All right. We're talking a lot about estrogen and stuff. I want to talk about my favorite substance, which is wine. Why can't I drink it anymore without waking up in the middle of the night? Why is it worse with red? Okay with white, better with champagne, but still overall, my favorite drink has kind of started breaking up with me as I've been.
Yeah, it's super sad, right?
It's. I would like to toast some wine to it, but I would be up all night. It's forced me to turn to cocktails. So is that a thing? Like, am I making this up? Because
I hear it from so many women that wine affects them very differently. Any kind of alcohol, for some, like you feel like I've had one glass of wine, I have like a hangover the next day, or I wake up in the middle of the night. And there's really two things happening here. With the decreased hormones in your body's not metabolizing alcohol the same way it did in the past. So it's going to affect you more or differently than it had. And so that may cause you to wake up in the middle of the night and not get the REM cycles that you would have gotten before, not have as restful sleep. But the other problem is, we talked about hot flashes and night sweats. We didn't talk about sleep disturbances, which are a really big symptom of menopause. And typically it is women telling me, I wake up at 3 or 4 a.m. and I just cannot get back to sleep. I'm just up, awake, brain done. And alcohol can often create that problem. But I think also the sleep problem in combination with the alcohol, you're going to you might have night sweats or hot flashes, and you're going to wake up sweating and you're going to wake up irritated. And then maybe because of that wine, you're not able to fall asleep as quickly. It also makes you pee more. So women are telling me I'm getting up to pee, during the night. So I think a combination of factors why that glass of wine may not be doing your body favors. I'd also just put out there, I am not, recommending that people totally eliminate it from their diet. It's always about moderation. But there's more about alcohol kind of being a little bit toxic. And the FDA actually the Surgeon General came out with a warning about alcohol. And we know that alcohol affects women more than men, and it takes less to impact us. So just something else to think about in terms of maybe moderation.
Yeah, we're all in mourning about that.
I know, it's sad.
Well, but also, okay, we aren't doctors, and Layla and I reside in the state of California. A lot of women I know, not saying Layla and I, but a lot of women I know have turned to other substances that may give us a little bit of the looseness and the lightness that we used to get from a glass or two of wine without the alcohol. I'm talking, of course, about THC. Not asking you to endorse or not, but like anything that you, because I will say that doesn't affect me the way wine does, and it gives me a similar buzz.
Yeah. No, it's, I live in California too, so it has been completely legal recreationally for quite a while. And again, I don't have any scientific evidence to say how safe it is or whether it's going to help with your menopause symptoms and sleep. But I have heard categorically a lot of women say it does. It does help them, and it can reduce the anxiety potentially that you may be feeling during menopause. It may make you sleepier than, you may have been before, and may help you sleep for longer periods of time. And I always kind of joke, like, a gummy has way fewer calories than a glass of wine.
Oh, amen, sister. That was my COVID discovery. It's like I could have 3 cocktails or like 1 gummy. It's like 5 calories.
Yes. Now, anybody who's tried THC will know that it takes experimentation to see what the right dosage is for you. And if you change brands or even, one variety versus another from the same brand, it can affect you differently. So it takes a little bit of trial and error to get it right for you and what's going to make you feel comfortable. But it does help a lot of people. Matter of fact, Dr. Lauren Streicher is one of the medical experts in this field. She has a great podcast, Dr. Streicher's Inside Information. And she specifically is doing some research on cannabinoids and menopause. And by the way, CBD also can help a lot of women with sleep or another symptom that comes up a lot is, and this is something I still have to some degree, is like joint pains or muscle aches, especially at night, or even like restless leg syndrome. And so I find that rubbing some CBD cream on my thighs before I go to bed really helps alleviate some of that at night. So that's my go-to.
Interesting.
Okay, I have one more question back to the hormones. So if we are in menopause for the rest of our life, do we do the patch and like all these creams? Do we do this for the rest of our lives?
Potentially. Again, I think the philosophy used to be like 5 years or the least amount of time needed. And it's always a possibility that your symptoms will change. Often they do. As you go further into menopause, a lot of the symptoms will decrease or go away. They could come back again. So just saying that. But there was like a philosophy that you don't want to use it for a long time. That is slowly changing. And again, it's done by a case by case basis with patients and their doctors to determine what's right for you. But I and other, a lot of doctors that I follow say, I'm going to go to my grave using MHT. Wow. And again, because things like the long-term health implications, I'll use osteoporosis as an example. So your bone density, your muscle mass is decreasing with a decline in hormones, and MHT can help you kind of maintain that. So if you go off MHT, you're going to lose some of those benefits. They're going to go away. So yes, maybe you didn't have the osteoporotic damage occur while you were on hormones, but when you go off, that process is going to start up again. So I don't want that to happen. I want to, I kind of feel that, we were existing on these hormones for half of our lives, and then we were thriving and feeling good. And all of a sudden your body is depleted of these things that were helping it thrive, which is another reason why we call MHT versus HRT. You're not replacing all of the hormones in your body. MHT is actually at a much lower level than what your body normally made before menopause. But long story short, I'm going to use it as long as I can. Now, I will say, maybe in a few years, I'll try to decrease my dosage and see how I feel and adjust if necessary. So MHT is not a static exercise usually. There's trial and error when you first use it to see what works for you in terms of form, level, et cetera. And then it's a process as you want to maybe wean down a little bit later in life.
Gotcha.
I have to say, I'm sleeping better than I have in 20 years. Now that I'm taking
awesome.
progesterone and got up to a dose, like it's changed my life. And to your point of taking it to the grave, like somebody would have to give me a really compelling reason to stop using it because I sleep through the night. Like, and I have not done that in so long. It's really
and how important is sleep? Like we're reading more and more how diminished sleep really can affect your mental health, your brain productivity. So sleep is one of the most important things we can do in terms of self-care and lifestyle. So getting good sleep kind of overrules a lot of other things.
What about all these other things like supplements that people are talking about? Like I have friends who are doing magnesium and there's turmeric. There's all these other things. Are those placebos? Are they like, might as well they can help too? I went to a whole lecture about like red thistle. I can't even remember half of them. I wrote them all down. I started taking them and then I said, screw it. And I started the hormones.
Yeah. I mean, I think you really want to talk to a nutritionist for in-depth information about what's right for you and your body and given your health history. But I'd say by and large, I've not seen evidence that a lot of these supplements are going to have the same impact as MHT in terms of, again, symptom mitigation, long-term health impacts. Now, that said, just from a health and aging standpoint, there are probably some nutrients you want in your diet that if you're not getting them from the food that you eat, you may want to supplement them. The best example, again, is calcium. For strong bones, you want to have calcium. Matter of fact, you have to increase your calcium during menopause from about 1,000 milligrams before to about 1,200 after. So calcium is like a must do in my mind. Vitamin D is another one that affects a lot of your body systems, but it helps you also absorb the calcium. So vitamin D is like, yes. And magnesium, as you mentioned, there are many different forms of magnesium, and some people take them to help them fall asleep at night. Some take them for digestive reasons. So magnesium tends to be one that spikes as well as like, yes, if you're taking supplements, that's a good one to take. Omega-3s is another one that comes up quite a bit. But I think myself included, I was totally over supplementing. I had like my tray with like my million different capsules morning and night. And now I've really actually pared back because I realized that a lot of supplements don't necessarily do what they're promised to be doing. Matter of fact, supplements are not regulated by the FDA. A lot of people don't know that. So there's not, the standards of a lot of checking on, okay, you have to have a really good supplement manufacturer to make sure what they're saying on the label is actually what's in the bottle and you're absorbing in your body. They did a study on melatonin and they researched like 25 different brands, and they found that like a huge percentage of them had more, like 300% of what was claimed on the bottle, or a way lower percent, or had other contaminants that weren't claimed in the bottle. So all I say about supplements is be careful about the manufacturers that you use and make sure they do third-party testing so that they know.
Allison, thank you so much. That's all the time we really have for today. But thank you, Allison Lewin, for joining us today. You can find a recap of everything we discussed today on our website at sideprojecthq.com. And you can learn more about Allison and all the awesome resources she just talked about on Menowar's website at menowar, that's menowar.net, menowar.net. Thank you so much for joining us, and we'll see you next time on Side Project.
No, it's my pleasure. Such a fun session. Thanks for having me.
Amazing. Thanks, Allison.
Awesome.
Bye.